Um, I want to thank you for this warm welcome. Before I just get started, quick show of hands. I know not many people here, but quick show of hands. How many of you have been diagnosed with a mental health issue? One, two, three, four. So as the statistics go, 25%, I'm guessing if this room was filled, I think it would have been a more valid statistic. But yeah, the 25% of the people in the world have a mental health issue, and 14% of them would probably have developed it by the time they're 14. And so today we're here to talk about ethics in probably one of the most critical, most regulated domains in the world, which is mental health. Just a bit about me. Most of my research work is actually in causality, in LLM hallucinations, and in needle in the haystack retrieval. I had data science for a mental health company called United We Care. If you're curious, you can just search for United We Care on the App Store, download the app, get the experience of what I'm talking about as we move along in this presentation. So we all know Uber, right? And we know that to solve the problem that Uber did, it had to create a user-side application and it had to create a driver-side application in order to make the entire ecosystem effective. We've done something very, very similar. We realized that if this is an ecosystem that we want to work on and this is an ecosystem that we want to lift, we'd have to end up creating both a user-side application and a clinical-side application. Both of these applications, while they do talk to each other, it is sitting at the heart of driving the entire flow that we're talking about, the entire interaction or the communication that we're talking about in terms of what the user is doing and what the clinician is probably looking at. And so the user-side application, as you can see, covers the entire 9 yards of mental health, from screening to clinical management, to relapse management, and to self-management. We have this entire ecosystem within the user-side application. For clinicians, what we've built is a clinical co-pilot system that essentially helps them create case history preparations for patients using AI, generate prescriptions, create follow-up summaries, create recommendations for the patient. And also, we have something called a Stella, which helps clinicians understand more about the patient in terms of retrieving the right information about the case, in terms of helping the clinicians understand what are the possible diagnoses that the clinician could look at, alternative treatment options, possible medication alternatives given critical cases, like let's say a patient has liver cirrhosis and then they have depression and then something isn't working out, so then what alternatives could a clinician probably explore? So these are the two applications that we have. And then, of course, there is a charter that kind of drives the heart of every decision that we take at the company, everything that we do in terms of enabling the solution that we talk about. Just briefly to touch upon these points: benefiting humanity, safe and transparent technology, collaboration and inclusivity, long-term responsibility, accountability in AI development, advancing knowledge in mental health, alignment with human well-being, clinical governance, and human in command. Now, I know while I said this is a mouthful to say, but how do we implement this? That's the question here. So while I dive into this, I just want to take a step back and to talk about a little bit about the evolution of generative AI, what we've observed in the last few years, the explosion of generative AI around the world. We started somewhere at level 1, which is chatbots, where language models or essentially generative AI at that point was more like a EA to a professional to most of the users or the use cases that it solved. And then we moved pretty quickly to a co-pilot level where AI could probably do very specialist set of tasks, not everything, but a few things very well. Up until last year, we were within the agentic flow framework where we had rule-based agents driving actions or decisions or steps that language models could take. However, this year, we've seen the explosion of autonomous agents, which are independently capable of taking decisions. Now, when we talk about human-machine interaction, there are 3 very popular frameworks or guiding principles that have come about. We have human on the loop, we have human in the loop, and then we have human in the command, right? Now, the difference between these three essentially decides how autonomous can you, or how much can you rely on these autonomous agents to actually drive critical mental health decisions or medical decisions at the end of the day. Human on the loop would be just having simple guardrails that are just driving language model generations or generative AI generations, which probably would not be very effective because, say, if it is an image generation, possible you can regenerate the entire image. But if it is something like a case summary generation, can you really leave that decision up to language models in terms of what it generates as a case for the patient? Um, the second is human in the loop, where possible that human will be a part of the loop in the entire process, but still, like a part of the responsibility stays with language models and a part of it with humans. And then we talk about human in command, which is where the human is actually in control of the entire process, in control of the entire flow. And the decision making at the end of the day lies with the human and not with AI, which I think is extremely critical given that we are now in a stage where we have language models, or sorry, autonomous agents taking entire decision making in terms of admission of a patient, to generating their case, to consulting clinicians, to everything that is involved as a part of the process. Given that, just a bit of our research focus, which I touched upon briefly earlier as well, I want to talk a bit about causality, one of the most challenging, one of the biggest unsolved problems in the world. Now, causality, in effect, has cause and reason, which is at the heart of what we popularly call reasoning at the end of the day. We know for a fact that language models cannot reason, and we know for a fact that language models will always hallucinate, and this is something that we've proved in our own research that we published a few months ago. Now, while we know this, we wanted to ensure that we leave language models to what they do best, which is just generation. We did not want language models to do any sort of creation, any sort of reasoning, any sort of understanding about a patient. And in that endeavor, we built the largest clinical knowledge graph in the world. It has about 16 million nodes and 220 million relationships. And this clinical knowledge graph is what is driving the reasoning behind everything that a language model generates. The language model at the end of the day is only responsible for generating and presenting the results in an understandable manner, but the entire reasoning comes from the knowledge graph that the LLM consults before any generation. And in this endeavor, we also realized that most speech recognition systems in the world don't understand medical text very well. So if you go to normally any speech recognition system and say Q-tip-in, it will understand that as QT-PI, and that's just the wrong medication that could probably go to any patient because there's no medicine called QT-PI. And yeah, of course, in that endeavor, we also broke like a few world records. We ended up building this vertical ASR solution along with the vertical knowledge graph that we built. And the whole idea was to ensure that we have a verticalized solution and a verticalized approach to building solutions for mental health. Similarly, a few intent detection world records that we broke. Now coming to the main reason why we're here, which is just understanding in terms of ethics, in terms of responsible AI, how do we drive the entire experience, how do we drive the entire process that here we're talking about clinicians, we're talking about users, how do we drive notice and explainability? The first solution that we actually implemented, and this is on the clinician side, is every single time a clinician creates a case for a patient, we throw up this disclaimer. We want the clinician to understand that this tool is only an educational tool. It is not a medical device and is not intended to be a medical device. We educate them that language models have the propensity to hallucinate, and it is extremely possible that the generation that language models carry can have incorrect information, can have biases, or potentially even harmful content. And it is entirely their liability to review the content that is generated from the models and not use that as judgment or medical advice. Um, and then finally, a couple of other things, which is, like because the responses could be biased and, because, sorry. Yep. We also talk a little bit about how we've used the clinical knowledge graph because in a sense, the clinical knowledge graph that we built, every patient whose case gets created on the platform also has a graph associated with them. And the clinician can use that graph to navigate the relationships, the information that they kind of need. So all of this information and caution is given to a clinician even before they create or start to create a case for a patient. And this is a reminder that is served to them every single time so that they understand the liability and what is at stake at the end of the day. For users, um, I think one thing to understand is that we want to ensure that AI, any generative AI, language models, any of this, we use it to screen and not diagnose. We want to ensure that language models do not do what clinicians do. They probably help as a part of screening the patient, but again, the results are something that should be communicated and discussed with a licensed clinician before any diagnosis or any conclusion is arrived at. So we have about 25 to 30 clinically validated assessments in the platform where we do not have any language model interference. These clinical assessments are validated by clinicians and the Pfizers of the world. What the user can do is they can use any of these assessments to screen for their case. But again, we give a disclaimer right before we begin and right after we end in terms of the fact that this assessment is intended for use by healthcare professionals and is not meant to be a diagnosis, and they should be consulting their clinicians or healthcare providers before they use any of this advice into effect. So one of the most strongest guardrails that we put in is to ensure that we never leave any of the diagnosing part to the language model or to generative AI, and only screening is left to extend to the user. And therefore, the explainability that we talk about also comes from these clinically validated assessments. We have a list of clinically validated inventories in the platform. And when a clinician actually goes on to consult a patient or understand what has happened, they can look at the scores of these assessments that the patient took, and then they can decide how they want to intervene or proceed in this entire endeavor, how they want to proceed with the medications, the diagnosis, etc. But this is always there as a layer of information that is provided to the clinician and is not used as a diagnosis in itself. We also have a very strong generative AI prohibitive use policy. And essentially, this prohibitive use policy is put in place to ensure that anybody who's using the platform in whatever capacity, whether that's a clinician or a nurse or anybody from the healthcare provider, they're not using any of our models in any harmful capacity. They're not doing any illegal activities basis this. They will not use any of the models to cause abuse to any of the patients or users they're working with, and that they do not generate any sort of sexually explicit content except for any information which is for scientific, educational, or artistic uses, and that they respect the ethical use standards that we have in the platform. And so also when we talk about human-machine interaction, we talk about biases. We all know that language models and any sort of generative AI, the biggest source of bias is the training data in itself, which contains a lot of harmful information, which contains a lot of which contain a lot of derogatory statements, a lot of hate, and you can see enough instance of that everywhere around the world. Unfortunately, we've used the same data to train language models, and all language models are doing is just propagating this bias from the training data around the world. And so a lot of us, when we think about the solution here, we think about how do we solve for that bias. And in that endeavor, where we try to go and solve one bias, we end up creating another bias. It could be a positive bias or a negative bias, but still at the end of the day, it is a bias that we're talking about. And so I would say that in the future, we'd have to look at first estimating the bias. Either ways, at this point, I don't know if, I don't think we know where to possibly intervene or what biases to solve for. And just to estimate the bias, sorry, and just to estimate the bias, we need to conduct a lot of randomized control trials, lots of them, to ensure that we first estimate and just understand the biases that we are talking about before intervening or before trying to solve for any of these biases. We need to ensure that we have more policymakers, we have economists, we have clinicians who are a part of this research and process that we are talking about, to ensure that to ensure that we do not have a lot of extra or additional or unwarranted bias that is creeping into these RCTs. While again, that might still be possible, the whole idea is to ensure that the sanctity of this research is upheld to the highest quality, to whatever extent we can. And I think the entire future of us, of humanity, of language models is going to rely entirely on how well we estimate for these biases and how we solve for them in the future. So that's my time, and I'm happy to answer any questions that you have.